Good evening, everybody. Good evening to all our delegates to the 12th episode of 4D Season 2.0. Now, as you all are all aware, 4D is details, discussions, dialogues in Indian diabetics, a much needed kind of seminar where we discuss more about Indians in perspective of their diabetes, their complications, all about diabetes and everything about it. So today, what we have is Dr. Beena Bansal. Well, it's my pleasure talking to her. It's so great to have Bombay, Delhi all on the same platform. Hi, Beena. Lovely to meet you again. And as I probably don't even need to introduce Beena, Dr. Beena is the founder and director of Door to Care, an endocrine and diabetes clinic at Gurgaon. She's also the president of Saksham, a type 1 diabetes welfare society. I had met her back in the day when she was the former director of the Division of Diabetes and Endocrinology at Medanta at the Medicity. Well, Beena, good evening and a warm welcome to you today.
Thank you, Pia.
And thank you, Beena, for being with us. And what Dr. Beena is going to discuss with us today is about diabetic foot and its complications. Now, like we're all aware, worldwide, actually, diabetic foot is one of the most common complications, a huge reason for admissions, and for that matter, humongous morbidity and mortality as well. So many different reasons: poorly controlled diabetes, basically peripheral vascular disease, peripheral neuropathy, and just poor foot care in general can contribute to all of this. And I think over here, educating our patients right, awareness and education, timely intervention is what's going to prevent a lot of patients from the morbidity associated with it, not to mention the amputations, which are such a kind of, let's say, serious, devastating outcome for so many patients. So with that very brief introduction, Dr. Beena, all over to you.
Thank you, Pia. I think you have already set the context, presenting the slides here. So we'll talk about diabetes and foot complications. As Dr. Pia already said, this is a common complication in diabetes. Around 6% patients with diabetes or even higher in India may be having foot complications, including ulcerations, deformities, and even amputation. So, diabetes is a prevalent disease. Around 10% of adults above the age of 80 are affected by diabetes. It's the second highest prevalence in the world, and 1 in 11 adults in India have diabetes. Many of them may be undiagnosed. So, these are the data we have: 90 million people, have diabetes, and 1 in 2 adult is undiagnosed. So the idea behind conducting lot of these education programs is so that we all can get together and take care of people with diabetes and prevent the complications which happen because of this and lead to a lot of morbidity and mortality. One of this being foot complication. The reason why foot complications happen is because of prolonged hyperglycemia. There is effect on nerves leading to peripheral neuropathy. There is effect on vessels causing peripheral vascular disease, which can lead to ulcers, sepsis, and even amputation. The leading cause of diabetic foot ulcer is diabetic neuropathy, and up to one third of diabetes patients may suffer from foot ulcers during their lifetime. Of all the hospital admissions for diabetic patients, 7 to 11% may be because of foot complications. So it is a complication which can lead to a lot of morbidity and mortality and very poor quality of life, because once the person starts having foot deformity, ulcers, it's a recurrent process. Having one ulcer increases the risk of second, and patients get repeated foot injuries, ulcers. Ultimately, it can culminate into amputation. So this is the data which we already talked about. 11 to 14% of patients in India in this study was shown to have foot ulcers. 6 to 23% of ulcers may ultimately lead to amputations. The global prevalence of diabetes foot ulcers ranges from 1.6 to 8%. It's more common in men as compared to women, more common in type 2 diabetes as compared to type 1 diabetes. And once a person has an ulcer, the chances of having second and third increases. The recurrence rate is very high, up to 40% within 1 year and 65% within 3 years. Um, how do we diagnose and stratify these patients, there are some staging criteria so that we can um, call the patients accordingly, refer the patients to higher centers. So, based on natural history, we classify the ulcers as normal, high risk, ulcerated, cellulitic, necrotic, or major amputation. There is Wagner's classification, which classifies these ulcers as 0, 1, 2, 3, 4, 5. Intact skin is 0. A very superficial ulcer is 1. Deep up to the level of tendon, bone, or ligament is 2. Uh, Once osteomyelitis sets in, it is grade 3. Gangrene of the toes or forefoot is 4, and gangrene of the entire foot is classified as Wagner's grade 5. So, how does a foot ulcer develop? Neuropathy is one of the complications of uncontrolled glycemia. Because of neuropathy, the person can have loss of protective sensation of the foot. It can also lead to foot deformity because of muscular weakness and joint rigidity. And a third impact of neuropathy is dry skin and decreased integrity. All of these factors may either because of one acute trauma or unnoticed repeated trauma can lead to ulceration, impaired healing, and abnormal plantar pressures, cracks and fissures. All these various factors ultimately can culminate into an ulcer on the foot. Peripheral arterial disease can contribute to this whole scenario by adding poor blood flow in the mix. So, ischemia can worsen the healing of the ulcers. It can individually also lead to gangrene and ulcers. And um, once infected, it can lead to septicemia and can be quite, the patient can have sepsis or amputation as a complication. One of the other part of the whole spectrum is Charcot's foot or osteoarthropathy, which again happens because of neuropathy, trauma, and inflammatory reaction. How do we assess the patient? Once a patient comes to us with a foot ulcer, uh, first of all, we have to see that the patient doesn't have sepsis and it is in a reasonable condition. So, definitely look for signs of sepsis, whether the patient is looking visibly well or unwell, drowsy, abnormal breathing, abnormal pulse, and fever. If these are there, the patient needs urgent admission uh, at a place where surgical or especially foot centers are present. Then examine the foot for active disease, whether there is ulceration, rest pain, gangrene, or cellulitis. Check the foot for temperature and color. Checking for temperature can help us assess whether there is inflammation, how widespread is the inflammation, or it can also help us to, tell us about the blood flow of the area. If it's cold, pale, or dusky, it may indicate ischemia. If it's warm, red, and swollen, it may indicate acute Charcot foot, and these are again acute conditions and they need most likely admission. Look for deformities. Check for lesions and deformities like deformed nails, callus, skin fissures, hallux valgus, claw toes, hammer toes, pes cavus, rocker bottom foot, fungal infection. So, carefully examine the foot. Screen for peripheral arterial disease by either palpating the posterior tibial artery and pedis dorsalis pedis. Ask for history of intermittent claudication or rest pain, and one can do a simple procedure in even in clinic based settings called ankle brachial index, which compares the pressure of the uh, pedal vessels as compared to the brachial vessels. And if the ankle brachial index is less than zero point 0.9, it points towards ischemia. And finally, look for screen for loss of protective sensation. One of the easy ways of doing it is by using monofilament or bioaesthesiometer. A low risk patient is where you see a callus alone. The patient needs adequate counseling, glycemic control is required, and look for other modifiable risk factors. If there is presence of deformity, loss of protective sensation, and or peripheral arterial disease, it's medium risk. The patient needs aggressive management for vascular disease, including statins, antiplatelet, exercise to improve circulation, and further referral if required, for example, for revascularization. A patient with a previous history of amputation or ulceration, or all these factors, lobs, peripheral arterial disease, and deformity, any two of these present is comes under high risk. and needs referral to a diabetic foot center for either callus debridement, for specific nail care, or for surgical management of wound or amputation. So it's a coordinated approach which we need for these patients. The follow up again depends on the risk category of the patient. I'll end the presentation whole discussion. Uh, Rather than managing the ulcer, the best would be to prevent any ulcers. And it has been shown that just some simple tips about how to take care of the foot, explaining the patient that they have to be careful not to ulcerate, not to get injured, goes a long way. In fact, 80% of diabetic foot ulcers can be prevented, and patient can be saved from a lot of morbidity and mortality by just giving these simple instructions to the patient about how to inspect their feet daily to look for any um shoe injury, any redness, any early pre-ulceration features. Because if intervention is done at this stage, then we can actually prevent the ulcer from happening. The patient also needs to be told that they have to examine also between the toes. Many a times the patient himself or herself may not be able to do it, and a caregiver needs to understand how to examine the feet, followed by washing the feet at an optimal temperature. It should not be too hot. With careful drying, especially between the toes, use of lubricating oils and creams for dry skin. Cut the nails straight. That is important to prevent ingrowth of nails. Do not remove corns and calluses using chemical agent or plasters. They should not be excised at home and must be managed by trained staff. Always wear socks with shoes and check inside shoes for foreign objects before wearing them. Avoid walking barefoot at all times. And they should maybe proactively ask the healthcare provider to get their feet checked at least once a year for patients with low risk. If there is any injury, they should immediately inform the healthcare provider. With that, I end the presentation, Pia.
Sabina, we are a little bit of a question answer that thank you, short, sweet, concise, and to the point. And that's the whole purpose of these 4D dialogues to get the message out. So, just to reiterate some of the more kind of salient points here, Bina, which kind of diabetic patients, in your opinion, are the most likely susceptible to develop diabetic foot ulcers, actually? Is there any
So,
certain kind of population?
so as I said, men have more predisposition to women, but I think all patients with diabetes are at risk. So screen for neuropathy. The best way to predict ulcer is someone who has callus, the risk of ulcer is very high. If it is a hemorrhagic callus, then within a year, the risk of ulceration is pretty high. So look for callus or any deformity. If possible, check with the monofilament. If the sensation, if the protective sensation is lost, you can easily check with the monofilament. That again predicts the risk of ulcer. So these are
Right.
simple tests. So looking for callus, looking for deformities like claw toes or hammer toes, because that can lead to footwear related injuries. The shape of the foot, if that is altered, then again choice of footwear becomes a very important measure. These patients can land up into with ulcers. Monofilament sensation not being able to perceive is a risk for future ulcers. And loss of blood flow. If the patient
Right.
has history of smoking, any other cardiovascular risk, patients who have CKD after transplant, the risk of ulcer is very high. So all patients who had undergone kidney transplantation, we specifically screen them and counsel them, because the risk of amputations are, ulceration is quite high in these group of patients. So
Right.
these are
Are we doing
additional
a
risks.
good job in terms of screening? Bina, what's your opinion, actually? I mean,
Uh, no, actually not, because it's a very easy thing, but it's very easily missed also, because you have
correct,
to go and look at the feet of the patient.
correct,
You have to have a paramedical staff to take care of it.
right.
It has to be part of a system where somehow every year the patient's feet are examined. It's not missed. So
Correct.
diabetes care is not just about knowing about how to do it, but how you make systems around making those care.
Those kind
By
of happen.
default, it happens.
Right. Agreed.
Yeah.
And then what do the guidelines say in terms of frequency? I mean, once a year is good enough for the patient who doesn't yet have a problem, is it? Right.
Yes.
Um, how often do you talk to your patients, Bina, about the education regarding this kind of thing? I mean, do you keep reiterating it? What do you think is the ideal way? Because there's so many things to talk about, really. And
And
so, how often do you find yourself actually doing it, really, is what I'm asking.
right, right. So I have a staff who kind of talk about these things. So I usually write. The initial conversation has to be from our side that you have to take care of your feet because there is a risk for injury.
Yes,
And then the whole list of precautions which they need to take, and this has to be reiterated again and again, especially if they are moderate to high risk.
right.
So either I mean, we ourselves can do it, but sometimes there are issues like time is a challenge.
Challenge
Uh,
always.
mm, so someone
How
in the clinic should be doing
it
it.
needs to be assigned, probably. Right.
Yes.
Are there any specific sites on the foot, Bina, that are more susceptible to injury and ulcers?
So sites which are prone to be like high pressure sites. So usually the plantar surfaces are high pressure, but patients who have hammer toes, etc., even the dorsum of these
Oh,
toes become high pressure. The place where the shoe kind of rubs along. If the patient is sitting cross-legged, then lateral malleolus becomes a high pressure site. So wherever
correct.
there is repeated trauma because of pressure is
Correct.
the site which is prone for ulceration.
Right. When do you refer a patient, let's say for an X-ray, Bina? What and what are we really looking for in an X-ray? Let's say. Yeah.
Definitely a non-healing ulcer when we are looking for osteomyelitis. That's the commonest indication. That's definitely a point where we want plain, simple X-ray.
Correct. And then do you do any further imaging after that, MRIs and all of that, which are diagnostic of osteomyelitis, or then you refer to a foot specialist by then? How does it work in terms of your clinic?
ABI we are doing routinely. So we do VPT and ABI in our clinics. ABI always is like incompressible artery. So there, that is the fallacy with ABI, and therefore the role of other screening measures for vascular flow, especially where you have strong suspicion of vascular insufficiency, then ABI is not sufficient. So if there is claudication, etc., then either duplex ultrasound or
Yes.
vascular surgeons do go for MRA. So MR angiography is part of ulcer management routinely. At Medanta, we had a vascular surgery department which would go because they need to also localize and plan the intervention.
Right.
So it's mostly done by vascular surgeons. Yes.
Correct. What are the commonest type of infections one encounters with these ulcers, really? I mean, nowadays the guidelines say that doing swabs is
Does
really not of the greatest value at all. But what are the commonest kind of infections, the bacteria that result in these kind of issues?
so it's streptococcal. Mostly it's polymicrobial. So we
Yeah,
kind of give a broad spectrum
broad spectrum.
antibiotic. We start with, of course, amoxicillin clavulanate in most patients.
Right.
Um, we have linzeolite and a lot of other things, but it's
Correct.
best to start first with amoxiclavulanate and
Correct. I think
then
staph,
see.
strep, and Pseudomonas E. coli would probably be the commonest
So hospital
reasons, right?
have
In
correct.
those. And of course, I guess all your linezolid and all of that come in when we are suspecting an MRSA. So I guess, but that probably we've referred out to surgeons, the vascular surgeon
Who
by
have
then.
recurrent ulcers and all, they kind of
Correct.
need
They
high
do. Correct. Because
antibiotics.
then also the question about when hyperbaric is indicated, if there's 30 days of a non-healing ulcer and all of that, I guess that goes into a more serious kind of foot care. How important is diabetes control, coming to where our role comes in? How important is diabetes control for prevention of these things?
So of course, everything starts with prolonged. So prevention of neuropathy and prevention of peripheral vascular disease itself starts with a good glycemic management from the very beginning.
Right.
Once the ulceration happens, then also optimal glycemic management, because by that time the duration of diabetes is long, the patient may be having complications. Uh, but with the wound there, I think trying to control as good as possible, aggressive management does become a thing as much as possible without causing hypoglycemia. So yes, so diabetes management is important all throughout. It's a mm,
Correct. Do you believe, Bina, in using antioxidants, micronutrients, the vitamins, etc., in your practice for these kind of patients?
so I, in general, do not prescribe many of these micronutrients. Not saying that they may not be helpful. I mean, there
Yeah.
may be studies, etc. But
Yes.
uh, the surgeons use quite a lot, so they do that
Yes.
job. Anyhow. patients.
Correct. But in your practice, you're not using much of that, it sounds like.
Yeah.
I know we already have such a large
Nutrition.
prescription
Yeah,
always.
nutrition becomes so protein intake, nutrition of
Yeah,
the patient, that is important, of course. But
correct. Correct. Right.
uh, how
But you're
much a
not doing the
supplementation of micronutrient will help, I am not sure about that.
correct. I guess there's always mixed studies on that kind of scenario. Okay, thank you so much. Bina, is any closing statement for you about how we can educate doctors and patients with regards to diabetic foot and its prevention?
So one thing which I tried and it worked, although now I don't have that, and I had put a, so the floor was little slippery, and I had to put something on the floor. So we had made those floor mats where diabetic foot care instructions were there. So fall
Okay,
prevention and foot care, we had put on the floor as like a stickable mat, which would make the floor also less slippery, and that worked because patients would sit and they'll read.
read.
They,
Right, how
it's
interesting. Correct.
uh,
And if it's on the
so
floor, then even more
we
pertinent.
make it easy for all the information to be seen, put on the wall, handouts.
Okay,
I think whatever works. But yes, so
yes.
educating patients about foot care is quite important in patients
Correct.
with
Do
diabetes.
you have a person that you refer to for foot care also? I mean, for making footwear rather. Do you have a person that you might be referring to also as well?
We collaborate with the company, so we have that pressure mapping, and we
Yes.
make those molds and all, and send the data, get footwear made. Yes, we do that for some
Correct.
patients.
All right. Thank you. Thank you so much, Dr. Bina. I guess over here, the awareness, the education, telling our patients to, just maybe after a shower, at least once a week, sit down on the bed, look at their own feet, because with the peripheral neuropathy and the feet are numb, they might not even have sensation to feel anything. And at the first sign of any injury, any callus, report back to us. Um, Things like just loss of hair on the legs is a little sign of peripheral, vascular insufficiency. So I think these kind of little clues that we as doctors and maybe even for patients to kind of realize is important as well. And this, of course, is a preventable morbidity, amputations. So I guess early care from our sides, education for the patients is going to be key in preventing a major quality of life destroying factor. Those are my words for the end of the day. Thank you so much to IJCP and end of the session.
Thank you, Pia, and